approach to youth with sexual behavior problems and their families. This is John Osowski. I'm the National Wraparound Initiative's Program Manager, and I'd like to go over a few announcements before we begin today's discussion. First, this webinar is brought to you in partnership with the Technical Assistance Network, so our thanks go out to them as well. Second, for best results, please check your settings on the audio pane if you are experiencing audio problems. During the presentations, you can send questions to the webinar organizer using the chat feature, but these will probably be held until the end. And please note that this webinar will be recorded and posted on our website within a few hours of the webinar's completion. And our URL is listed on the slide in front of you now, nwi.pdx.edu/webinars/html. And now I'd like to take a moment to introduce our guest speaker. Our guest speaker today is Stephen Gilbertson, a Wisconsin licensed psychologist with over 30 years of clinical and administrative experience working with families and systems. Mr. Gilbertson has been involved in program development and evaluation activity as a member of the Wraparound Milwaukee management team since the beginning of the program in 1994. His work within Wraparound Milwaukee has emphasized the promotion of viable community-based alternatives for youth considered at high risk for out-of-home placement. Mr. Gilbertson has authored successful grant proposals in order to initiate community programs needed to fill identified gaps. Most recently, Mr. Gilbertson has partnered with youth advocates, medical and legal partners in a grant-funded project to address the complex needs of commercially sexually exploited youth in Milwaukee. Mr. Gilbertson has provided training and consultation locally, statewide, and nationally, and has authored several professional publications. He has been a clinical and research member of the Association for the Treatment of Sex Abusers and has been appointed to and served on several boards, including the Wisconsin Children's Trust Fund, the Ruddy Memorial Youth Foundation, the Milwaukee Child Abuse Review Board, the Juvenile Justice Review Board, and the Partnership Council of the Bureau of Milwaukee Child Welfare. So we'd like to welcome Mr. Gilbertson today. And with us also today is Dr. Eric Bruns, co-director of the NWI. He is a clinical psychologist and associate professor at the University of Washington School of Medicine in Seattle. He is co-director of the Washington Children's Mental Health Evidence-Based Practice Institute and chair of the Board of Advisors of the Research and Training Center on Children's Mental Health at the University of South Florida. Eric conducts research on innovative community-based models for helping youth and families with complex needs, including family treatment drug courts, parent support programs, and the wraparound process. He is developer of the Wraparound Fidelity Assessment System and editor of the Journal Report on Emotional and Behavioral Disorders in Youth. He has published over 20 peer-reviewed articles and book chapters on the wraparound process. And with that, I would like to turn things over to Eric.
Good morning or good afternoon to everyone on the webinar, and thanks for joining us today in the latest of our series of informational webinars that are intended to support providers and systems that are implementing the wraparound process. Before I thank Steve one last time and hand the reins over to him to discuss this very important and interesting topic about preventing sexual harm in youth, using community-based programming and wraparound, wanted to just talk real quickly about a few upcoming National Wraparound Initiative events. So the webinar series will continue through the rest of the year. We have 3 more events scheduled. Well, actually 2 more events scheduled, both in September. We're going to take a bit of a break during the summer. And in September, on the 16th, we will be presenting a webinar that discusses methods through which states have built the capacity to provide intensive care coordination using the wraparound model, which should be pretty fascinating for those who are either part of statewide initiatives to try to take wraparound to scale, setting up fiscal and other kinds of structures to support wraparound implementation, or are functioning within a state system. So that's Tuesday, September 16th, and some of our guests on that webinar will be Sheila Pyries and Diana Simons from Human Services Collaborative as well as the Center for Healthcare Strategies, talking about what they've found nationally as strategies for statewide wraparound implementation. On September 30th, also a Tuesday, we will have wraparound office hours where folks can submit their questions to a panel of National Wraparound Implementation Center experts about implementation on the ground level, organizational level, or system level. Anything and everything that you would like to ask about implementing wraparound care coordination and the necessary services and supports to support it, we will be available to answer your questions. Last thing, as you know, the Georgetown Training Institutes are coming up in July in Washington, D.C., July 15th through 18th, I believe, or maybe it's the 16th through the 19th, I think 16th through the 19th. And wanted to let folks know that on the first day of the Institutes, July 16th, before the sessions formally start, there will be a National Wraparound Initiative annual open house and 10th anniversary party from 2 to 5 p.m. We will be streaming that live via webinar for those who can't be there, to have cake in person, but we will be celebrating our 10th anniversary and talking about all the new directions in which the National Wraparound Initiative is going, including the launching of the National Wraparound Implementation Center. So that's enough about the NWI. I would like to now turn it over to Steve Gilbertson. And I just wanted to very briefly say thanks to Steve for volunteering to spend an hour or a little bit more with us to present on this topic. In my travels across the country working with wraparound programs, there's often this question of, can wraparound care coordination and the associated clinical services that are available to wraparound teams actually mitigate the risks of sexual harm by young people who may have that in their history? And can we actually work with these youth in the community using a wraparound model paired with intensive services and supports? Steve is here to tell us about ways in which they've innovated methods for serving these kinds of very complex needs populations in Milwaukee County. And we are just thrilled that he's here to share his experiences with us. As John said, if you have questions that you'd like to ask or comments, please feel free to type those into the chat box. And every once in a while, I'll probably break in to, where appropriate, get those answers from Steve. So Steve, take it away. I'm looking forward to hearing your presentation.
Thank you very much, Eric and John, for that wonderful introduction. And I'm very pleased to be with you guys today. I'm hoping that my voice will hang in there for about an hour. We've got kind of an inversion here, so it has a little bit of an impact on my voice at times, so I apologize for that ahead of time. John, if you could go to the next slide, please, just to make sure that works. So greetings from Milwaukee. Those of you that haven't ever been to Milwaukee, I certainly encourage you to come during the summer. It's a beautiful time to be here, obviously. And Milwaukee is a city of festivals. This week, starting Wednesday, we've got Summerfest going on, which is the largest outdoor musical festival in the world, supposedly, with all kinds of acts. I think Bruno Mars.
Bruno Mars, he did a great Super Bowl show, right?
Yeah. He's going to be starting the show off on Wednesday, and there's a great lineup to follow for the next 10 days or so through the 4th of July. So that's a fun thing to do. Milwaukee has great restaurants. Obviously, we're on the lakefront, Lake Michigan, Lakeshore, and great sailing opportunities, and we get a little coastal cloudiness this time of year, similar to San Diego and San Francisco, but in general, it's a great place to visit. So I certainly encourage you guys to come and spend some tourist dollars and help us out. Next slide, please. So today, my aim is going to be to, as succinctly as possible, share the Milwaukee Wraparound story of program development specific to working with youth and families affected by sexual aggression, juvenile sexual aggression, and reflect on some values and some lessons we've learned as a product of coming to serve this particularly complex needs group. Next slide, please. So Wraparound Milwaukee, we began as a system of care in about 1994 with a system of care federal grant, which allowed us to essentially do infrastructure development and transform the children's mental health system in Milwaukee over a period of years. That initial grant was for $5 million, and we have been a model of sustainability, I think, across the country. We're often called upon to share our sustainability story, and our CEO, Bruce Camrad, is kind of a fiscal wizard and is in high demand to talk about how we've done that. But essentially, we've become a Medicaid HMO, so we get a cap rate for every youth enrolled in Wraparound. And right now, to this day, we've got about 1,100 youth and families that we're serving, and that's kind of the average enrollment. We serve both system-involved, juvenile justice and child welfare system-involved, and non-system involved youth. It's about a third of our kids are non-system involved at this point. We have a mobile urgent treatment team that serves the entire community. They do mental health crisis intervention. They go to where the family is struggling and help them to prevent psychiatric hospitalization, prevent other types of interventions that might not be in the kid's best interest, like arrest, for example. And they've been very, very successful in diverting kids. The utilization of psychiatric hospitalization has dropped like a rock in Milwaukee over the last 10 years to the point where we used to have our own psychiatric hospital, which was one of the largest child and adolescent treatment centers in the United States, with about 125 beds that were constantly full. And now we've got, we're down to about 9 beds on average with kids in the hospital for all of Milwaukee County. So that's pretty significant change, obviously. Wraparound Milwaukee, in partnership with our family advocacy organization called Families United, has really been a catalyst for significant system and reform in Milwaukee. And we persistently aim to promote the core values shared by the National Wraparound Initiative and the System of Care movement. Next slide, please. Next slide, please. Hello? There we go. So in about 1996, after a couple of years of working exclusively with child welfare involved kids, Wraparound Milwaukee became the provider for the juvenile justice system for those kids that were at risk for out-of-home placement with serious emotional disturbance. And at that point, we began to get a trickle of kids with who had been adjudicated of sexual assault. And most of the kids at that point that had been adjudicated of sexual assault within the entire system were being sent to residential treatment on the front end or to correctional facilities. So about 18 to 20% were going to corrections right off the bat, and about 60 to 70% were going directly into residential treatment centers on the front end. At that point, there was only one local community-based offense-specific treatment program, and they were serving really very, very low-risk kids, and they weren't documenting well, and they didn't have great credibility with the court. Next slide, please. So as I say, as we began to get referrals from the juvenile justice system of kids with sexual behavior problems or kids that were adjudicated of sexual offenses, some of us didn't feel terribly comfortable just doing what we had been doing with child welfare involved kids and families. And we took very seriously the community safety and victim safety concerns that came along with this population. And while we felt like that the system at that point was overly conservative and risk averse, we also felt like that we wanted to know what we were doing before we really took on this population. So we engaged in kind of the evidence-based process, which starts with a very thorough literature review and consultation with then national experts. And some of the things that we discovered through that process was that what had been discovered across the country was that kids that engage in sexually harmful behavior are a particularly diverse group, very heterogeneous, not homogeneous, and that they reflect, a variety of family, environmental, and mental health needs and risk for reoffending. And we also discovered that it was critical to the eventual viability of community-based programming to, as early as possible, determine which kids could be safely treated in the community. And that required some risk assessment, obviously, to be part of what's available to the court. It was also noted that in communities there was a tremendous need for local data to inform the program development. There was not a lot of research within communities that really detailed who was coming before the court and what the outcomes were and that kind of thing. And there was a need for viable, credible, community-based alternatives to institutional care so that kids could be credibly treated in the community. If they matched with, from a risk and need standpoint, if it was felt like that they were a good match for community-based care, we needed to have community-based care that was high quality and credible to the court system. Next slide, please. So what do we do to kind of move in that direction? We felt like that we needed additional information to be brought into the entire system of care and essentially to allow for training of our community partners and to raise awareness of what best practices were. So I applied for a technical assistance grant from the Center for Sex Offender Management after consulting with them over the phone and chatting with them for quite some time about kind of our conundrum. They were very happy to provide us with a small kind of micro grant of about $90,000, which allowed us to bring in a few strategically important experts. At that point, we brought in Dr. Barbara Bonner, and who was from the University of Oklahoma Health Sciences Center at that point. And Barbara Bonner had been had for many years been doing outpatient work with kids who had been adjudicated of sexual offenses, and she had done some very good clinical research. She was very knowledgeable, very experienced, and a great speaker. So we brought her in and invited both providers who had an interest in working with this population and our system partners, both within the child welfare system and the juvenile justice system. So we brought in DAs and judges and probation officers and all those wonderful people to listen and learn from somebody that really had great experience in working with this population and doing so in a less restrictive sort of way. In addition, we created a policy-level cross-system and multidisciplinary team, which included judges, victim advocates, public defenders, probation, child welfare, evaluation experts. And so we would meet on a monthly basis and study the literature together. I would distribute literature to all the partners, and we do our homework and come in and essentially discuss what we had learned from reading about what other people had done and really beginning to kind of strategically plan about, you know, what is it that we want to do in our community to address this need and do a better job with these kids, their families, and their victims. And so out of that, we began an initial pilot research project, which allowed us to begin to collect data on every single kid referred on a sexual assault charge to the Milwaukee County Children's Court. And we gathered information on what they allegedly did and to whom. So it really looked specifically at the behavior that was engaged in, who the victim was, what was the relationship to the victim, what were the other circumstances of this kid's life, did they have any prior charges, what was the legal outcome, and what was the eventual mental health outcome for these kids. So we got them at the very front end, and then we tracked them longitudinally, and eventually we tracked all these kids for up to 5 years. So we had great long-term outcome data. Simultaneous with that, I had a doctoral student that was working with me from the University of Wisconsin-Milwaukee psychology department who was looking for a dissertation project, and what he did was he began to, with the same instrument that we had developed for following these kids prospectively, he went 5 years prior. He retrospectively looked at the population of kids referred on sexual assaults 5 years prior to the implementation of what we were doing. So the aim was to create kind of a great comparison group looking at what were the outcomes, you know, from a legal standpoint, from a mental health standpoint, and from a, you know, long-term recidivism standpoint, both from a sexual and a non-sexual recidivism standpoint. So we began that very comprehensive research project. I had an excellent evaluation person working with me at that time who was a great statistician and just was great to work with. So we started, I mean, this was a very high quality project, if I do say so myself. So in addition to that, we implemented the chief probation officer was in favor of us designating a couple of probation intake workers who would handle all sexual assaults. So we had, I think, 3 specialized probation intake workers who went through the training and were also trained on the instrument to collect the data on the front end. And then the idea was to have them become specialized, but then to have them disseminate their expertise and wisdom to the broader group of probation intake workers, and that's what eventually happened. So we were doing all of this on without external money, and then we applied for a federal grant which was offered through the Department of Corrections and the Violence Against Women Act at that point. And it was they had both planning and enhancement grants, and we were able to get the enhancement grant, which allowed us, I think we got like just under $400,000. And that allowed us to do some additional things as far as training and implementation. So so one of the other early enhancements that we did, since we were beginning to take some of these kids into Wraparound Milwaukee, we designated a high-level administrator, myself, to provide oversight and to be kind of the point person so that the court system, everybody knew who to call if they had questions. And then I began to provide what we called community safety resource development consultation, or high-risk consultation, and review for all kids enrolled who were adjudicated sex offenders. We later expanded the high-risk list to include a number of other kids, most recently youth who have been involved in commercial sexual exploitation. So it's just a way for us to provide another level of clinical oversight and consultation and coaching to care coordinators and providers and other team members that are involved. Next slide, please. And John, you're doing a great job, by the way. Thank you. So what were some of the early outcomes for this project, which was kind of a mini project within Wraparound Milwaukee initially? And so one of the outcomes was during the first year of implementation, $400,000 public dollars were saved, despite the fact that we were serving more families than was the case before the implementation. And we were doing it in a family-based way. We were working with the entire family. The system previous was very much, as I said, sending most of these kids into residential treatment centers, oftentimes geographically distant from Milwaukee. And that posed tremendous challenges to engaging parents and certainly made it difficult to be victim-centered and to work toward restoration and healing in a healthy sort of way. So again, we saved a lot of money on that front end, and we continue to because of good decisions being made on the front end, which were made possible by the implementation of specialized offense-specific assessment, risk assessment, and resource development. So prior to this project, we were getting psychologicals kind of generically on all kids enrolled in Wraparound Milwaukee, but we didn't have specialized offense-specific or sexual offense-specific risk assessment on board. And so the psychologicals were very generic and were not specifically addressing the questions that really the court needed answers to, or at least some clue about in order to make decisions that they felt comfortable with. So we implemented that, and what we found, obviously, and this was consistent with what the literature had suggested, was that a very high percentage of kids that come before the court really are pretty low risk. Most of the kids were first-time offenders, and many of them didn't have a lot of other kind of characterological or personality concerns that would put them in a high-risk category. But there were some kids, and certainly there continue to be some kids that should be considered pretty high risk. Only 8% of the adjudicated sex offenders incarcerated in 2001 were incarcerated in 2001. This is in contrast to 19% the previous year and 20% in 1996. So again, fewer kids were going into residential treatment, fewer kids were going into correctional placements, and again, it was all related to a different process on the front end, which the court, because I think in part because of our policy team and the collaboration that was going on and the growing awareness of what can work with these kids and what risk really looks like, all of that was contributing to different decisions being made by the judges. The DAs were also part of our process, and the chief DA at Children's Court was on our policy team and was very supportive of everything that we were doing, so that made a huge difference. The other thing that helped was that we were tracking recidivism very carefully, and despite the fact that we were shifting toward community-based, less restrictive, presumably, approaches, and when I say less restrictive, it really is not less restrictive. It's just that the containment is based on relationships versus bricks and mortar. But at any rate, our sexual recidivism rate was hovering at about 7%, and the base rate nationally for treated kids tends to hover around 10%. So we were actually beating out the national averages. And again, most of the communities across the nation were using much more restrictive care than we were. Next slide, please. So what do we/you need to know in order to improve your approach to youth who have been sexually harmful? And again, in developing this presentation, much of it I took from some of the training that we do for our care coordinators. I spend about 3.5 to 4 hours with newly hired care coordinators, orienting them to the work with this population of kids and families. And so the following information is some of the stuff that I share with care coordinators, just to kind of help them to be aware and be prepared to do their job as a coordinator, as somebody that is trying to facilitate a community-based approach. Okay, so next slide, please. So to work with youth who have been sexually abusive, their families and victims, one needs to become and remain aware of the bigger picture of child sexual abuse, its impact, its incidence, its etiology, and the best practice interventions. I mentioned earlier the Center for Sex Offender Management. They're a great resource. If you go to their website, they've got all kinds of information, including training curricula, and that can be shared with judges and with your community partners. They've got just a plethora of information. It's a fabulous resource, and they're nice people. I mean, if you call them up, and like us, if you want a technical assistance grant or whatever, it could be that they still have some money. I'm not sure, given the federal government's issues these days, but certainly they're a great technical assistance provider. In addition, in working with, if you want to go back, I'm sorry, John. I'm sorry about that. The other big kind of piece of information that I think it's very important to be aware of in working with this population is just the trend nationally to integrate trauma-informed care and trauma-informed ideas into the whole wraparound process. And so, as we all know, a very high percentage of the kids that we work with within wraparound across the country are kids that have been exposed to, and oftentimes repeated exposure to traumatic circumstances. And so we really need to make sure that we're being using best practices with that population. So the National Child Traumatic Stress Network, established by Congress in 2000, has a great website. The Chadwick Center in San Diego is a great resource for some information about trauma assessment and programming. The USC Adolescent Trauma Training Center has a manual for integrative treatment of complex trauma for adolescents. It's a treatment guide. It's excellent. So all of that stuff, I'd encourage you guys to take a look at if you're interested in serving this population. Next slide. So one of the things that in my training and consultation with care coordinators that I'm very aware of is just the impact of doing this work on the worker themselves. And certainly I can speak to it from personal experience. Over the years, I've done about 1,000 offense-specific assessments myself. I'm constantly reviewing petitions, reading the details of sexual abuse that's occurred. It's pretty tough stuff to process and to live with sometimes. And so it's very, I think, important when people are kind of beginning to get into this area, to remain aware of secondary trauma and the symptoms of secondary trauma. And this list is some of the things that one might experience as part of that. And depending on your personality, you may be more vulnerable to one or the other. And some people have argued that I was predisposed to some and not to others. But at any rate, that's if you want to go to the next slide, John. So one of the things that I've shared with care coordinators recently is this study that looked at judges, and they found that 63% of judges on the bench for 1 to 6 years had reported work-related secondary trauma, including sleep disturbances, intolerance of others, physical complaints, depression, and a sense of isolation. The judges who had been on the bench for 7 or more years actually experienced even higher rates of these symptoms than the judges that had been on the bench less time. So there is this thought that the longer you do this work, the more likely it is that your defenses, your ability to manage the symptoms begins to kind of break down a little bit, because there's a cumulative effect of being exposed to all this stuff. So I think that's very important to remain aware of. Next slide, please. So in order to do this work, it's very important to take care of yourself, since you're presumably one of the instruments of change, which is an incredibly important role to be in with families. And these are some of the, when people have been interviewed, these are some of the stress-reducing activities that people have mentioned have been most effective. And this is in order of vote, so to speak. And cultivating a sense of humor is number one. And I think that I know that there tends to be a lot of joking around within our program, and I think that's and silliness and just being goofs, and I think that that's critical to my mental health. I know for a fact. If I was Mr. Maturity and Mr. Serious all the time, I'd probably be a candidate for cardiac arrest. So in addition to a sense of humor, having a healthy, intimate, and family relationship, having one or more healthy relationships at work in which one can express feelings, having enjoyable hobbies and leisure activities, that's very, very important. There's a group of us here that golf together, and I sail, and I do different things, hike and bike, and try to stay as active as possible. Having relationships with professional peers who aren't in your field of endeavor. In my case, I'm married to a psychologist, but thankfully she doesn't do the exact same kind of work that I do, so we can talk and commiserate and detoxify with one another without feeling like we're just telling each other the same story. So in addition, avoiding and self-monitoring potentially harmful approaches to stress management like smoking, drinking, risk-taking, cynicism, and negativity. I think, it's not unusual that people go through periods of increased cynicism, and thankfully the wraparound approach is very strength-based, very positive, and we do a lot of stuff in our team meetings, management meetings, to highlight the successes and discuss, what's going well. So all of that, I think, helps people to survive. Our wraparound management team has been, we've stuck around. The core group of us, there's about 5 of us that have really been here since the very beginning. Certainly there's more turnover in our private partnership groups within care coordination. There's inevitably turnover, but we monitor that and try to if we see agencies that are struggling, we try to provide additional technical assistance and support. And we're really trying to improve our approach to trauma-informed care with providers. So next slide, please. So what is sexually abusive behavior? Certainly, if we're going to work with it, we kind of need to know what it is. So it is sexual interaction with persons of any age that happens against the victim's will, without consent, in an aggressive, exploitative, and manipulative or threatening manner. So again, this is sexually abusive behavior. Next slide, please. It's important to, I think, remain aware, when you're looking at statistics that relate to sexual abuse and its incidence, that you remain aware that 86%, it's estimated that 86% of child sexual abuse is never reported to authorities. And so certainly in the work that we do, we want to increase the likelihood of reports, and that requires a lot of public education, a lot of preventive work, and so if you're going to work effectively in your community around sexual abuse and sexual abuse prevention, it's very important to partner with agencies and with other organizations that have that as a priority. And some of the boards that I've sat in on have shared that mission. So that's been very important to our project and our work within Wraparound Milwaukee to have those partnerships with other like agencies. Next slide, please. So I'm sure many of you are aware of the ACE study, which involved almost 20,000 HMO members out of, I think, out of the San Diego area. It was a multi-year study. They were essentially looking at aversive childhood experiences amongst their HMO enrollees. And this was just a generic health HMO. And they were looking, they were trying to determine if these aversive childhood experiences were in any way related to later health outcomes. And I think they were pretty surprised by the results, which suggested that the number of aversive childhood experiences that were alluded to or reported was directly related to later health outcomes. So more aversive childhood experiences, shorter lengths of or shorter lifespan, other tremendous health problems related to certain childhood experiences. The other thing that they found was that 22% of all the people that responded reported that they'd been sexually abused as children. So that includes both males and females. 66% of the women experienced abuse, violence, or family strife in childhood. Next, please. So child sexual abuse is a major problem. I mean, there's more and more people kind of characterizing child sexual abuse as a major epidemic and a public health problem in our country. And it's highly likely that you know a child or a person who's been sexually abused. 1 in 4 girls and 1 in 6 boys are thought to be sexually abused before their 18th birthdays. And again, since the reporting there's a tremendous underreporting of sexual abuse, so it's conceivable that these numbers are actually an underestimate. But the way that they've gotten these numbers is through random digit dial studies, which kind of preceded the move toward cell phones and people being on the no-call list. So they would call up people and ask them to anonymously respond to questions related to childhood experiences, and those that they did connect with, these numbers kind of represent how people responded, and these were huge studies. Next slide, please. So who sexually abuses children? Again, in order to serve kids who have sexual behavior problems, we need to kind of be aware of the bigger picture of incidents and just what sexual abuse looks like. So the unfortunate reality is that 90% of child sexual abuse incidents, the child and the family know and trust the abuser. So it's friends and family are really the most likely abusers of children, sexual abusers of children. And approximately 1/3 of sexual offenses nationally against children, young children, are committed by teenagers. And again, oftentimes it's a relative, a cousin, a sibling, some relative. Next slide, please. So in Wisconsin, the data suggests that most of the known victims are female. We know for a fact that males are even less likely to report sexual assault, sexual abuse than are females. So those numbers, again, are probably a little skewed because of that. The median age of victims is 9 years old. The most common type of sexual assault is forced fondling, and only 4%, on the average, 4 to 6% of sexual assaults reported are committed by strangers. And this, again, kind of flies in the face of the mythology of the whole stranger danger. I mean, certainly child abduction does happen, and certainly with the advent of the internet, there's more dangers for children in interaction with people that are not family and friends. So some of the landscape is changing. Next slide, please. So who are juvenile sex offenders, or kids with who have been found guilty of sexual assault? So youth who commit illegal sexual behavior, sexual assault, who are found delinquent. So that's the legal definition. So kids that are adjudicated of a sexual assault are juvenile sex offenders. Each state has a little variation on the law as it relates to what's legal with regard to adolescent sexual behavior. In this state, in the state of Wisconsin, it's illegal to have intercourse before you are 18. It's legal to engage in petting with somebody in a consensual manner if both people are 16. And so it's very important to kind of know the law in your local jurisdiction. This is stuff that kids are unfortunately not educated about. Their parents are not educated about it. It's not something that there's a lot of, PSAs about, unfortunately, which probably would serve to prevent some of the things that happen. So that's important to know. Most youth who sexually abuse are never involved in juvenile justice because of lack of reports, as we've talked about. The kids that do come before the court are a diverse group, and they commit a range of illegal sexual behaviors, ranging from limited exploratory or curious behavior to repeated aggressive assaults, sometimes even including weapons. So again, we need a broad continuum of care in order to really serve the diversity of this group. So next slide, please. So the other thing that we know about kids that get into trouble for sexual behavior is that early adolescence is a particularly high risk and to some extent transitory developmental period for committing illegal sexual behaviors. So the average age of kids referred on a sexual assault in Milwaukee County, for example, is about 13 and a half, and the average age of their victims tends to be 8 and a half. So again, if you think of middle schoolers, we can all imagine, and know what's going on with middle school age kids and the vulnerability they have and their difficulty managing their sexual conduct. Next slide, please. So in Milwaukee County, really only a fraction of kids are adjudicated of those that get referred on sexual assaults. So on the average, 95 to 100 of the 350 to 400 kids that are referred on sexual assault actually get adjudicated. Over time, when we first started with Wraparound Milwaukee and started taking juvenile justice kids, we started out with only about 9% of the adjudicated sex offenders coming to Wraparound Milwaukee. Now, kids that are adjudicated, we get about 70 to 95% of the kids who are adjudicated of a sexual assault. The Department of Corrections placements have continued to remain very low. Two of the Department of Corrections institutions for juveniles have closed over the last 10 years, and that's in large part because of diversions that have come as a product of Wraparound Milwaukee, because most of the kids that were going to correctional facilities in the state of Wisconsin were coming from Milwaukee, and that's no longer the case. So two of the facilities closed. We only have one left, and it serves both males and females. Most of the kids referred to Wraparound Milwaukee are first-degree offenders, and that has a little bit to do, if not a lot to do, with just the age of the victims. As one might imagine, most of the victims are under 12, and again, the offenders are only 13 and a half, so just by virtue of them being under 12, they're charged, the offense is charged as a first-degree offense. Most of the people that we get are boys with female victims, and I've already said the average age of the victim is eight and a half. And most of the victims of the kids that are enrolled in Wraparound Milwaukee, they're intrafamilial victims. Next slide, please. So another thing that, kind of contextual piece of information that we need to be aware of if we're going to work with and, interact with our system partners around kids with sexual behavior problems is just to kind of remind ourselves what is natural and healthy sexual behavior for kids. It is possible for kids to interact with each other in a sexual way without it being abusive. And I think our court system, at least here locally, has really tried to differentiate something that is illegal just by virtue of the status of the people involved, to differentiate that from something that's truly abusive. So one of the things that's important to remember is that, all human beings are sexual. That's part of our nature. It's part of who we are. It's a healthy part of who we are. 40 to 80% of children engage in at least some kind of sexual behavior before they're 13. Children in healthy sex play are of similar age, size, and developmental status, and participate on a voluntary basis. So these are kids that want to play with each other. They're having fun. Most sex play is between children who have an ongoing, mutually enjoyable play and school friendship. Sexual behaviors are limited in type and frequency. The child's interest in sexuality is balanced with curiosity about other aspects of life. Natural sexual exploration may result in embarrassment, but does not usually leave the child with deep feelings of anger, shame, fear, and anxiety. And if discovered, these kids will stop. So, next slide. So that's in contrast to what we might consider problematic child sex behaviors, where there is no mutual or ongoing play relationship between the children. So, for example, if you've got a young person who moves into your neighborhood and suddenly they're setting up a tent in the backyard and inviting kids to play sexual games in the tent with them, that might be a problem. And that comes from an actual situation that we had here in Milwaukee. So the children are usually of different ages or developmental levels. When it's not a healthy thing, the child seems to be sexually preoccupied versus, having a variety of interests. So they may have a lot of sex talk, and they seem to know too much. Their sexual interest and behavior mimic adult behavior. Their sexual behavior stands out relative to peers. We've had situations where children in daycare and preschool settings are, grabbing teachers and making, obscene comments to their teachers and grabbing other kids and humping them and all kinds of stuff. So obviously that's not healthy, and it's certainly a red flag and needs some intervention. The sexual behavior often persists despite the fact that people are encouraging the kid to stop and trying to prevent it. Child appears driven. The sexual behavior is eliciting complaints. And oftentimes the sexual behavior progresses in frequency, intensity, and intrusiveness over time. Next slide, please. So the next question for us, and the stuff that we really kind of need to be aware of, is the literature and what's known about the etiology of child sexual behavior problems and eventual sexual assault. So next slide, please. So one of the things from a community standpoint that is, I think, a factor is that some communities, some states, really have no standardized required curriculum for sexual health education. And many of the kids that I've evaluated over the years really have only had, a brief discussion within a health class about sexually transmitted diseases and that kind of thing. They really don't cover the law. They don't cover what a healthy relationships look like. This is in contrast to many of the Scandinavian countries, which integrate healthy relationship training and education about our bodies and all of that stuff, in an age-appropriate way, year after year, starting in kindergarten, and they integrate the parents into it, and it's very much accepted and pleasant and comfortable kind of thing for kids to talk about, which results in people, it prevents sexual abuse if kids know what's going on and can talk about it openly and don't feel ashamed and are comfortable. So we've got a long ways to go in our country. I think there's pockets of things going well with regard to education, but it's certainly not where it should be. The other thing is that there's consistently the research and just anecdotally, the information suggests that most kids get their primary information about sex from the media. It used to be, MTV, increasingly with the advent of tremendous internet access and internet-based pornography, kids are at very early ages being exposed to hardcore pornography. And so it used to be that when I would interview kids and I'd see petitions relating to sexual abuse between kids, the history of the perpetrator often included some kind of direct sexual abuse experience. However, increasingly, that's not the case. But what we do discover is that the child has become very interested in pornography and has had easy access to it, and that has made it very difficult for them to control their sexual impulses. Next slide, please. So this little diagram is a nice, in my way of thinking, is a pretty good way to depict how it is that sexual abuse occurs. So the person on the left is the potential perpetrator, and the person on the right is the potential victim. And so and you've got vertical barriers like normal sexual outlets, conscience, lack of opportunity, and victim's resistance that kind of stand in the way of the person on the left committing a sexual crime with the person on the right. But you also see kind of blocks that, like steps over those barriers. So in the first case, to the left, you've got a blockage, you've got sexual arousal, and you've got emotional needs. Well, what does that mean? First of all, what are normal sexual outlets for a 13-year-old? And by sexual outlets, the way that I think about it is, what's the normal way for kids to get their affectional needs met at that age? And you know, through their peer relationships, through their family relationships. Kids need attention. They need physical affection. They need to be able to talk about how they feel and feel some level of intimacy with friends and with family. And many kids obviously don't have that opportunity, or there's been some kind of disruption in their family that has made it difficult for them to get those needs met. And you combine that with, you know, going through puberty, possibly being exposed to either your own sexual abuse, which certainly complicates one's life in many ways, or just pornography exposure. And in some cases, the kids' attitudes about sex don't allow them, or they don't feel comfortable just simply masturbating as a way to have a sexual release. So that all of that would kind of bump them over that normal sexual outlets or normal affectional outlets kind of barrier to the next potential barrier, which is conscience or kind of moral development. And as we know, you know, moral development is still kind of in process for early adolescence. And certainly kids that have had family disruption, kids that have attention problems or socio-emotional immaturity are sometimes slower to integrate social norms and understanding of wrongfulness around certain situations. Certainly if a child has been sexually abused or they've been exposed to pornography as their primary understanding of what sex is all about, then their sense of wrongfulness about that has been shifted, perhaps, or has been profoundly impacted, and it makes it difficult for them to have their kind of internalized moral development stand as a barrier to them doing something with a young child if the opportunity presents itself. So the next barrier is lack of opportunity. And again, for some kids, that is a huge barrier. They're never around younger children. They're never alone with younger children. They aren't babysitting. They don't have younger siblings. They don't have younger cousins, nephews, nieces. But on the other hand, there's a lot of teenage or early teens who are put in babysitting situations despite the fact that they may be kind of impulsive, they may not have the best judgment, they may have been sexually abused, they may be watching porn while babysitting. So obviously, if that's the case, then that whole issue of lack of opportunity dissolves completely. And then we're over to the last potential barrier, which is victim resistance, which, if it's a young child, the likelihood of that child resisting is not great. Kids that want to abuse younger children will often, essentially groom them, bribe them, sometimes force them, but force tends to go up with, the likelihood of force tends to go up with the age of the victim. So if the victim is a teenager, then the likelihood of there being a force is much, much greater than if the child is a 4-year-old, obviously, for obvious reasons. So, next slide, please. So in each individual situation that we're confronted with and we're trying to work with, we want to kind of develop a theory and as good an understanding as we can regarding the factors that may have contributed to the individual child that we're working with engaging in the behavior. And we need to know the history that contributed to the vulnerability and strive for a holistic understanding of the youth and family and the risk factors that may be more treatable. So we want a very individualized sense of etiology and work from there. We want to understand kind of what needs to change, both from the standpoint of inside the youth and outside from the environmental standpoint, to lower the risk of the child engaging in further sexual misconduct. And next slide, please. So this is a list of some of the factors that can contribute to risk for engaging in sexual misconduct or recidivating once somebody has been identified as having engaged in sexual misconduct. There is certainly, with the population that we work with, there's a high incidence of complex developmental trauma, or trauma 2, it's called by some people, which is where there's been a repeated exposure to aversive childhood experiences, and that over time can result in, essentially brain changing, personality changing, character changing kinds of activity. And many of the kids that we work with, most are coming from impoverished families, high rate of parental incarceration, high rate of residential instability. Parents are often challenged to provide supervision and to ensure treatment compliance once they're enrolled, and that's something that we try to focus on, and that's one of the strengths of Wraparound, is that we can really flexibly assist families in filling those gaps. Some of these kids will have trouble engaging meaningfully in treatment, and again, Wraparound across the nation has been shown to really improve the likelihood of kids engaging and completing treatment of all types, but we've certainly found locally that we've got really high treatment completion rates with kids that are in Wraparound. Trouble following a safety plan, again, in a traditional situation where you've just got an outpatient provider and a youth and maybe a probation officer and their parent, a safety plan may just feel like it's a piece of paper that's in somebody's file, whereas in Wraparound, it's something that's reviewed regularly. There may be multiple safety plans that are context specific. So there might be one for school, there might be one for the bus, there might be one at home, there might be one for holidays, that kind of thing. Those are made up on an as-needed basis and revised on an as-needed basis. And the partnership between the family and the care coordinator and the providers is all about collaborating around safety. Truancy and running away, again, this is a risk factor if that's happening, and thankfully, again, within Wraparound, we've got people that do tracking. If a child runs away, there's a very quick response. We've got partnership with the local police, and we've got crisis stabilizers that go out and look for kids and interview various people to kind of determine where they're likely to go, and we try to recover them as soon as possible, obviously. Peer group concerns, substance abuse, these are risk factors for just generalized delinquency. History of multiple offenses is obviously puts kids in a higher risk category. History of repeated non-sexual offenses puts kids in a little bit higher category, and persistent sexual preoccupation is another risk factor. Next slide, please. So from a risk and need standpoint, we want to be ecosystemic in our assessment, and person times environment equals risk is a good formula to just kind of keep in mind. as we try to understand kind of relevant contextual factors that can contribute to risk, and the personological factors as well, so that we're really understanding the interaction between this specific person and their environment, which may be changing, and both the person and the environment hopefully are changing as a product of intervention, which would lower risk. Next slide, please. So this, I showed you a picture of the kind of the east coast of Milwaukee. This is unfortunately a not too uncommon scene in the inner city of Milwaukee, where somebody's been evicted, and this is certainly something that many of our youth have experienced, sometimes multiple times, and so that kind of experience is just one of the kind of contextual factors that environmental or personological factors that affect these kids. Next slide, please. So there are a couple of kind of evidence-based risk assessment tools for sexual offense-specific assessment. One is the JSOAP-2, Juvenile Sex Offender Assessment Protocol, and then the ERASER. And I think that's estimated risk assessment, sexual offense risk assessment, something like that. I don't know what it stands for, but most, at this point, again, I mentioned this earlier, but most, if not all, of the kids that are adjudicated of a sexual offense in Milwaukee now get a risk assessment, and they typically need to have that re-administered at different points during their enrollment in Wraparound. So if there's a change of placement from a restrictive placement to a less restrictive placement, or if there's thought about a child moving home, then there will be a re-administration of a risk assessment and other assessments of both the youth and the family to really determine what the needs are. The other thing that comes up toward the end of enrollment is the question of sex offender registry. And in our state, judges are allowed to, they're allowed discretion in determining whether or not a youth who commits a sexual offense is on the registry or not. And so that decision is stayed usually until there's been a completion of treatment. And most of our kids do not end up on the registry unless they reoffend. Next slide, please. So there are different types, broad types of kids that get into trouble for sexual misconduct. There are offenders of young children, and they typically present a little differently than offenders of peers and adults. These kids tend to be quieter, more reserved, less aggressive, and more likely to offend against relatives. Next slide, please. Offenders of adults and peers tend to look more like kids that have gotten into trouble for kind of generalized delinquent behavior. Oftentimes they have used force or weapons. Oftentimes they abuse substances, and they usually have a non-sexual offense record as well. Next slide, please. So one of the things that we've done locally, this is data from Wraparound Milwaukee, where we use the data collection instrument that I talked about earlier, and we looked at what kids actually have done and been found guilty of. And this compares kids that committed a crime against a young child versus those that committed a crime against a peer. And you can see that there is a big difference in many cases in terms of what behavior is actually happening. So the kind of lighter blue-green color versus the purple. The lighter blue is the child molestation. The purple is the peer sexual offense. So you can see that in the peer situation, there's more touching of breast. There's actually more touching of victim's genitalia when it's a young child. There's actually more penetration of the victim when there's a young child. There's more verbal coercion or manipulation. There's more physical force when it's a peer. So you can see that, you know, young children that are being abused often are being abused in a very intrusive sort of way, versus peers that fight off the perpetrator may just be forcibly fondled. That's not to minimize that, but relatively speaking, it's a less intrusive act. Next slide, please. So here, this is comparing incest versus non-incest offenses, and again, it's kind of a similar layout to what we saw before, in that the victims that are within the family are more likely to be intruded upon, either through penetration, through touching of genitalia, and there's more verbal coercion and less physical force. So again, you know, when the family relationship you know, is there, it's more likely that things escalate and grow over time, whereas the peer offenses tend to be one-time interactions and are limited by virtue of that. Next slide, please. So these are the kinds of things that we tell our care coordinators on the front end. We really, not to frighten them, but we certainly let them know that if you've got a youth that has committed a serious sexual crime, that it needs to be taken very seriously. It's a huge responsibility. Not that we're going to hang them out on their own, but they need to do their part in reading all the material, the referral material, the psychologicals, all the history. We have this high-risk consult form, which I'll show you in a second, which is part of our internet-based management information system. So care coordinators can go onto their computer and punch in the information that's requested ahead of my consult with them, and then they're all prepared, and it's a pretty efficient process of me looking. I go into our consultation with a laptop and can pull up the entire record and look at that while we're discussing what's going on, so I get a really holistic view of what's going on with the kid. I can look at progress notes, I can look at provider notes, I can look at the plan of care, I can look at the juvenile justice record. It's pretty cool, actually. So care coordinators are expected to document well and keep up to date. They're definitely not. They're definitely discouraged from being a Lone Ranger, and because this is very much it needs to be a shared responsibility. We encourage them as soon as possible and right out of the gate to build a team that's very positive, holistic, strength-based, and victim-centered. Very promote open communication, and we want to build competencies while also managing risk. We have critical incident reports, which again are part of our management information system, so that if something happens, the care coordinator enters that into their computer, and then I can see it immediately on my computer, and then we can respond and consult and deal with things that come up. Next, please. So this is the high-risk consultation form. I won't go into this in detail, but you will have it, as part of the slides that you can download, I presume, at a later time. Next slide, please. So one of the questions that we ask in there is, what is the team's priority at present? We ask for kind of their sense of the stage of change that the youth and family are at any given point. We want to make sure that the youth is attending offense-specific treatment if that's what they're in for. So we've got good questions, I think. Next slide, please. So when care coordinators are first assigned one of these youth, they really need to carefully read the petition. They need to know what the youth did and to whom. They want to engage in victim-centered sensitivity and concern. They want to engage the caretakers to address supervision needs. And they really want to assess, along with other team members, the caregiver capacity and where they are at this point. We found in our own local research that there's a high rate of maternal depression in situations, particularly where there's been sibling incest or any kind of intrafamilial abuse. As you can imagine, the loyalty conflict that parents are thrown into is just tremendous and is very stressful. The whole legal process is incredibly stressful. So by the time that a youth is enrolled in Wraparound, if they've been adjudicated, the family's been kind of through a ringer. And so the care coordinators are tuned into that and really come in with a lot of empathy, but also with the expectation that the family wants to heal, that they don't want this stuff to happen again, and they want to partner with us to prevent it from happening again, and that they'll be very, very cooperative and part of the partnership. So next slide, please. So it's important to be aware that most sexual abuse does happen in one-to-one situations involving an adult or adolescent and one child. Most occurs in the home of the victim or of the offender. So that should play into our safety planning. Obviously, if we can just prevent this young person from ever being alone with a younger or more vulnerable child, then it's very unlikely they're going to commit another sexual assault. And it is possible to achieve that for several months until they're farther along in their treatment and are more likely to have integrated the things that they need in order to keep themselves and other people safe. Next slide, please. So I don't know, how are we doing on time? Can somebody answer me that?
Steve, we are about 8 minutes from the end.
Okay.
We have not gotten any specific questions. What I will suggest to the group, one of the specific questions was right before you started talking about the specifics of care coordination principles for this population of youth and lessons learned in facilitating wraparound with these youth. You started getting into that. So I would say try to nail down as much of that as you can, which I think you're in the midst of right now, and I'll monitor for any other questions.
Okay, sounds good. All right, so yeah, we are in the midst of kind of the nuts and bolts of care coordination. One of the things that obviously immediate safety, treatment engagement, all of that is the priority on the front end. And next slide. Okay. So it's important for care coordinators and for our partners to really kind of understand what is the story with treatment, what is it that works, and does it work, and at what rate does it work. And what we found, what the research suggests is that, as we mentioned earlier, the base rate of recidivism, sexual recidivism for kids that complete treatment is 10% or lower. So if you're predicting that one of these kids is going to commit a new sexual crime, you're going to be wrong about 90% of the time. And we want 0%, but it's a pretty low rate of recidivism for kids that complete any therapeutic intervention, really. Non-sexual delinquency appears to more consistently be a problem as far as recidivism. However, in Wraparound Milwaukee, we've had very low non-sexual recidivism with our kids that are considered to be kind of in our high-risk group. So those numbers, that 8 to 58% is really, ours lingers around 8%, 8 to 10% of non-sexual recidivism. Mentoring is a very powerful and effective intervention with these kids. It allows them to get out in the community, to have some adult role modeling, and to not be, sitting around the house with nothing to do and not learning new skills. Motivational interviewing is a evidence-based practice. It's great for engaging these kids and their families on the front end when they're they're frustrated about the whole legal process, and we want to engage with them. Groups, kind of a warning is that group therapy is a common technique used across the country, but we don't want kids to be expected to disclose their offense history in a group. And that's partly because of something that happens in those groups, which is deviancy training, so that kids are learning what other kids did and sometimes are getting ideas. So that's not something we want. We want more of a skill-based approach within groups, psychoeducational approach. The only randomized controlled trial support for offense-specific treatment has been multi-systemic family therapy. Functional family therapy and wraparound are considered promising practices just based on the data. We've done our own research and published some of that, and that's helped to support the idea that wraparound is a great way. Next slide, please. So I think probably most of you are familiar with the whole stages of change thing, so I won't go into detail about that, but it is an important thing for care coordinators to be aware of and to kind of understand and be conscious of where their child and family are on this continuum, and that it's not a overnight process. It takes time to change. Next, please. We do have some girls with sexually aggressive behavior. Most of the kids that we are referred for adjudications of sexual assault are boys. However, there is a small group of girls. They tend to be girls who have truly had horrific histories of trauma exposure, and their treatment really needs to be taking that into consideration. Oftentimes it's a babysitting situation that girls are involved in that results in them engaging in some kind of sexual inappropriateness with a younger child. Next slide, please. We do have a certain percentage of our kids adjudicated that have pervasive developmental disabilities or lower intellectual functioning, and we've developed specialized programming for those kids that matches their ability to comprehend and integrate new learning. We work carefully with their parents, caregivers, to make sure that they're carefully supervised, because that's a huge issue. And a lot of times these kids are not necessarily going to be able to independently follow the safety plan, so longer-term planning around that is needed. Developmentally disabled folks in general are at high risk for being victims, so because of that, they are at somewhat elevated risk for engaging sometimes in sexual misconduct that they've learned about through their own victimization. Next slide, please. So this is the very last 4 slides. And in working with this population, what we're really aiming for is restoration and healing. And next slide, please. So these are some of the outcomes that we'd like to achieve. We'd like the child victim, if there's going to be a reunification, we certainly want them to independently and in their relationship with their own therapist to state that they're okay and comfortable with the reunification. They can acknowledge and discuss the sexual abuse. They don't blame themselves, which is a huge issue in terms of cognitive attributions that tend to happen in sexual abuse situations with young children. We would like them to be likely to report further sexual abuse, obviously, and to feel safe. And the age of the victim is heavily weighted. Certainly with very young children, it's much higher risk, and we rely very heavily on the caretaker's capacity to keep the younger child safe. We want to make sure that the treatment provider that's working with the child victim is going to stick around and continue to work with them and amplify their voice once the juvenile is back in the house. Next, please. So the offending adolescent, we want them to accept full responsibility. We want them to be able to apologize with genuine remorse. We want them to have true empathy. All of this stuff it requires a lot of fine-grained work with these kids, both within individual, family, and group therapies. All of our kids get those three modalities, plus they're working usually with a crisis worker, their care coordinator. They have multiple people on their teams that are constantly monitoring how this young person is thinking and their willingness and ability to process what's happened, and our ongoing assessment of whether they truly get it in terms of what they need to do differently. Next. So the caretaker capacity is a huge issue. If we're going to be able to reunify, we absolutely need the caretaker to put the victimized child's needs first and be able to hold the offending adolescent accountable and enforce a safety plan, to be able to discuss the abuse openly. Openness and communication is a huge outcome to shoot for with these families, and it's not easy. It's something that can take a very long time. And we do have kids that do not go home. Oftentimes they're in a relative placement, they're in treatment foster care, or some of these kids matriculate into independent living because it's just not possible for them to achieve what's needed to be achieved while they're still a minor. So, but we need a partnership with the caretakers that is highly credible in order to be able to get these kids home. Next slide, please. So this is and again, we're almost done. Right now, there's currently 58 or 60 adjudicated sex offenders in Wraparound. Only 5 are in residential treatment, and you can see where the others are. 23 are at home. And again, the kids that are at home typically don't have an intrafamilial victim, but some do, and that, again, is something that takes a lot of work. Next slide. So again, this is just showing sexual versus non-sexual recidivism. Sexual recidivism is the line, the orange line. Non-sexual is the other line. And this is like meta-analysis kind of information, and it just basically shows that non-sexual recidivism is much higher than sexual recidivism in general. Next slide, please. So, and this is within Wraparound Milwaukee. On the right-hand side is 1-year follow-up information, 4% sexual recidivism during enrollment, and this was a few years ago actually, 11% during enrollment recidivated. Next slide, please. So I'm not going to go through all of this, but I'd encourage you to read this. Obviously, Wraparound is not easy, and care coordinators, in order to work with this population, really need high levels of support. They are the agents of change in the trenches, and oftentimes are fighting system partners, not necessarily fighting, but certainly are challenging the system partners in their stance about what's in these kids' best interest and everybody's best interest. Next slide. And fidelity drift, certainly the National Wraparound folks have worked on fidelity and have done a fabulous job. It's very difficult to maintain fidelity to any model, but certainly one as complex as Wraparound requires lots of support and also ongoing strategic planning and learning from our mistakes, and we're very fortunate to have a great management information system and a management team that really highly values strategic planning and looking at ourselves on a regular basis and trying to constantly improve. we've got a huge QA department as well that monitors everything that's going on. So next slide, please. So I really appreciate everybody hanging in that hung in, and it's been my pleasure to speak with you. And certainly if you have any questions, feel free to contact me, and good luck.
All right, Steve, this is Eric. I really appreciate the time you've taken. We're a few minutes over. Fortunately, the questions that came in related universally to issues you then brought up, including the latter points you made about planning for youth with developmental disabilities. So since we are over time, we'll thank everyone for participating. Not seeing any additional questions. Remind folks that all of these slides, as well as a recording of the webinar with slides and narration, will be available on the National Wraparound Initiative website. And one last time, encourage you to continue to tune in to our webinar series and to attend our open house and institutes that are specific to the NWI's work at the Georgetown Institutes in DC next month. So Steve, any parting words that you'd like to leave us with?
Only that it's been a pleasure to participate. I really appreciate what NWI is doing to improve quality of wraparound and making sure that everybody that wants access to wraparound can get it across the country. I think it's just fabulous. So thank you for all the stuff that you guys are doing. I really appreciate it.
All right. Well, thank you for being our guest today, and we'll see those of you on the who've been in attendance at a future NWI event or somewhere else out there. Good afternoon, everybody.
And thank you.